So I think when we face these type of situations, maybe the first question that we should be asking ourselves is, why did this happen? With the hopes that we can avoid these things from happening again. And when we look at these two pictures, I have to tell you that I think we're conditioned to think, when we see the picture of the left, we're conditioned to think the way we usually think when we see the patients on the right. And that's the reason why is because we're created by them. This is probably maybe due to hard brushing, this may be due to the position of the tooth. But when we have the patient on the right, this patient has already visited a dentist. This patient has already been in the hands of a dentist. And this is a man-made condition, if you want. Where on the right side, we have a problem that really has been developed with time, and the patient or the dentist is not really responsible for. So what I want to say is that we, dentists, are responsible for the image on the right. And if that is the case, we should be discussing about how can we avoid to have these conditions in our dental practices. I understand that we are kind of geared to treat, but before we discuss treatment, we should probably discuss how can we avoid these situations. And the only way to avoid these situations is to understand how do they occur. And that's what I will be discussing with you today. We'll be discussing mainly soft tissue deficiencies, and soft tissue deficiencies encompass mucosal dehiscence, encompass fenestrations, and encompass also discolorations, but I today will only be focusing on the image on the right, which are mucosal dehiscences, as Silvia explained. These are apical migrations to the soft tissue margin that expose part of the prosthetic components that make a longer crown, and we may use adjacent or homologous teeth to see if the tooth is longer than the other ones. So, as I was saying, when we have these type of conditions, and if we look at the literature, we basically see that this has been referred as having a multifactorial etiology. And what that means is that there are several factors that contribute to the development of these conditions. So, you look at the literature, you may find it's the implant that is responsible because the position is incorrect. You may find that it's the osseous tissue that is responsible, maybe because there's not enough, or maybe because it's too thin. You may find that perhaps the abutment has been trained to be responsible because it's poorly designed, or that we have an over-contour crown. And you may also find that perhaps the soft tissue has been blamed for this mucosal dehiscence, perhaps because it's too thin, or perhaps because we don't have enough keratinized tissue. Now, mind you, when we say multifactorial etiology, it's a very fancy word to tell you, we really don't know why this thing happened, right? And this is what we saw. This is a publication in 2013. And really not up till more recently, we've started to understand really what are the most important factors that contribute to the etiology. So what we did in Madrid is basically gather up to 30 cases, and this was just a pilot study. These are cases that I saw in the private office, and basically what I tried to do in a very empiric fashion was try to understand and gather a number of data and try to understand what were the factors that were related to these mucosal dehiscence. So I'll just show you very quickly one case. This is a canine, and you can see when I draw a line compared to the contralateral, you see that clearly the crown is longer. And this is the image when I take a look at the occlusal aspect. I remove the crown, I check for the position of the implant. Obviously the implant is completely outside the alveolar envelope. It's also angulated facially. So now we start to understand why are we having this problem. So back again to these 30 pilot first cases that I gathered to try to understand or to try to answer this question. I have to tell you that only 4 of them I consider to be implants appropriately placed 3-dimensionally according to the prosthesis that the implants had. So this means that most of them had a problem with the position of the implant to begin with. Now, I have to tell you that this was not something very scientific. We pulled cases posterior and anteriors, we had overdentures, we had different types of prostheses. So together with my friends Ignacio and Sanz, Alberto Tibiron, and Ignacio, we came up with something that would be a little bit more scientific, and this is what we published recently. I'll be showing you this publication later. But I also wanted to show you a part of my PhD thesis here was done under Professor Mariano Sanz at the Universidad Complutense de Madrid. And basically what we came up with is that we built a three-dimensional model. And with this three-dimensional model, we could better understand basically volumetrically three different compartments. And that was the buccal bone, the buccal aspect of the implant, the soft tissue volume below the implant shoulder, and the soft tissue volume above the implant shoulder. And this helped us to understand better what is the interplay between the soft and the hard tissue. Because the key is not one or the other, but probably both of them and how they interact with each other, and what is the interplay, so that we can better understand, how do we have to treat our patients. But there was something here that we didn't evaluate, and that this model really helps us to better understand, and that's the position of the implant that we were discussing before. So what happens to the soft tissue and the hard tissue